Hello everyone. Today I'm going to be talking about the abducens or the sixth cranial nerve. The abducens nerves or the sixth cranial nerve supplies only one muscle in the orbit, the lateral rectus. It is the most common isolated cranial neuropathy and consists of inability to abduct the eye and horizontal diplopia. As you can see on this image, when the patient looks towards the right, his eye does not cross the midline because of the pathology to the sixth nerve. Now, let's start with the nucleus of the sixth nerve, for which we have good landmarks. If we look at this diagram on the left, we see the sixth nerve nucleus with the nerve going anteriorly to exit through the pontomedullary junction. Now, the motor nucleus of the seventh nerve sits right next to the sixth, and the fibers from the motors go posteriorly, curve around the nucleus of the sixth before they go anteriorly, joining the parasympathetic and sensory fibers of the seventh. So because of this turn of the nerve, of the facial nerve, we get this bump on the floor of the fourth ventricle, calling the facial colliculus. And we can see nicely on this MR these two little bumps. Those are the facial colliculi, and the sixth nerve and the seventh nerve nucleus sit right anterior to those colliculi. Now, usually on a regular T2 image, we're not going to see very well the sixth nerve. You just see a shadow of it here. And if we do thin T2s, you can see they're quite obvious. We can see them anterior to the pons. Here again, on the Netter's diagram, we see the 2-6 nerve coming out at the pontomedullary junction. And here they are on the specimen. Now, sometimes we will only get a portion of the sixth nerve, the anterior portion, and here a little more of it. But if we angle the slice appropriately, we will see the entire sixth nerve. Usually it's the same angle we need to see the seventh nerve going into the internal auditory canal. Sometimes we'll even see both six nerves on a diffusion DWI image, as we can see over here. Now, the sixth cranial nerve travels anteriorly and enters an important structure within the clivus, and that is the Dorello's canal. As you can see here, here's the bony clivus. There's a little cavity in there with the sixth nerve sitting within it. The usual name that everybody's used to is Dorello's canal, but now there's a new name called the petroclivis venous confluence. Now, how this name came about is it's the junction where the clival veins join the cavernous sinus and the inferior petrosal sinus. And the sixth nerve, arachnoid, and dura pass through this venous complex below the petrosphenoid ligament, also known as Gruber's ligament. So if we look on this side, which is not the sector, we can see the sixth nerve traveling within the venous plexus towards the Dorello's canal. So again, here it is on the anatomic specimen, the nerve within Dorello's canal, and we can see it, the nerve on the MR traveling towards Dorello's canal. And again, here it is entering Dorello's canal, and here we can see it within Dorello's canal. Why Dorello's canal is important, you will see later in the pathologic cases. And of course, Dr. Castleman from Belgium always shows it the best. Here's an MR showing the sixth nerve sitting within the CSF in the Rayleigh canal. Very similar to what we can see on this specimen. We can also identify the sixth nerve on a sagittal MR. Again, on the specimen, the nerve is vaguely seen here coming out of the pontomedullary junction, just like in this diagram over here. But notice that we can see it on a sagittal T2. Here's the sixth nerve traveling superiorly, and here it is again traveling towards the Rayleigh canal. And we can actually see in the specimen, this is the sixth nerve within the Rayleigh canal. Notice on MR I found this image showing again the sixth nerve entering the Rayleigh canal, and again sitting within the Rayleigh canal on the sagittal plane. And of course, again, Dr. Castleman from Belgium shows that the best. Here's the entire cisternal portion of the sixth nerve traveling anteriorly, entering and sitting within the Rayleigh canal. Now, this case that I showed when I was talking about trigeminal neuralgia showed this very ectatic left vertebral artery impressing on the trigeminal nerve. But what I want to show, also this case showed beautifully, was again on the sagittal plane. Here's the sixth nerve coursing towards the Rayleigh canal, right next to the ectatic vertebral artery, although this patient did not have sixth nerve symptoms. Now we can also identify the Rayleigh canal on the coronal plane, which is important again for pathologic cases. If we look at this diagram here, so here's the sixth nerve entering the Rayleigh canal, the trigeminal entering Meckel's cave, and the third nerve superiorly at the level of the dorsum. And if we look at this anatomic specimen on the coronal plane, here's the third nerve. This is the chiasm over here, the clivus. Here's the sixth nerve, and laterally is Meckel's cave with all the nerve fibers. And we can see the same thing on a similar coronal T2. So again, this would be where the third nerve sits. This is the Rayleigh canal with the sixth, and here's Meckel's cave with all the trigeminal fibers within it. Now, I was surprised to see what I thought were two sixth nerves. So here's, for instance, one sixth nerve. Then I saw another nerve next to it, which on other images was like a complete sixth nerve. And sure enough, there are occasionally two sixth nerves. And again, Dr. Castleman shows here two trigeminal nerves in the cistern, and here on the axial plane, and here they are on the coronal plane. Now, it turns out that already in 1974, Professor Nathan demonstrated the various anomalies of the sixth cranial nerve. Here's a single nerve coming out of the pontomedullary junction, traveling all the way to the lateral rectus muscle. Sometimes the nerve splits into two in the middle portion, and there are two divisions here, or you may have two nerves coming out of the pontomedullary junction joining together within the cavernous sinus, or you could have two completely separate sixth nerves all the way to the lateral rectus. Okay, here we have a patient with both sixth and seventh nerve palsies. And why do we have both nerves involved? Again, if we look at this diagram here, you see the close proximity of the seventh nerve nucleus to the sixth. So as many times the pathology is a little more extensive than what we see on MR, we can understand why both nerves would be involved in this with this stroke, which we can see on the diffusion imaging. Here's another, in this case only a 6th nerve palsy due to a stroke. You can see just anterior to the facial colliculus, and in this case only involving the 6th nerve. Now again, as I said last week, when we have oculomotor nerve palsy or trochlear nerve palsy or INO, intranuclear ophthalmoplegia, they all look the same, and it's very hard to separate them without having some clinical history. The same thing relates to the 6th nerve, where we see a stroke here, and a patient with INO. It's very similar. If you look in the midline here, this patient had an INO, and it's very similar to this patient who had a 6th nerve palsy. And that's again because of the close proximity. So here's a patient with a 6th nerve palsy because of a stroke. And notice on this diagram, here's the 6th nerve right next to the MLF, the medial longitudinal fasciculus. So they're very in close proximity, and sometimes it's hard to tell if you don't know the clinical history. And again, here's a patient with INO, and again, notice the close proximity of the 6 to the medial longitudinal fasciculus. Here's a patient that presented with a 6th and 7th nerve palsy. What is the pathology here? Please, on the chat box. Correct. A new pathology Dan mentions, multiple sclerosis. Notice first of all the abnormal signal here on the T2, and we have a little bit of enhancement in the regional facial colliculus. Notice also that this, on the thin T2, this colliculus is slightly larger because of a little bit of edema compared to the normal side. So again, this is MS. Here's a patient who had an isolated 6th nerve palsy, again an MS patient, and we see the abnormalities on the T2 and on the flare, as well as enhancement, again, involving the region of the 6th nerve nucleus. This unusual case where a patient with MS and had both 6th nerve involved, see the midline lesion, and again, on the diagram, they look separated quite a bit, but you can see on MR they're very close together. So in this case, both of them were involved. Here's a patient with lymphoma. He had the 6th nerve palsy, and again we can see the abnormal signal again in the location of both the 6th and the 7th nerve nuclei, but this patient only had a 6th nerve palsy. 18-year-old was a 6th nerve palsy. What is the possible etiology? Not mentioned so far. Correct. Then again, Lyme disease. This is a patient with Lyme. Of course, it looks no different than the other conditions, but again, we see the abnormal signal in the region of the facial colliculus. There's also abnormal signal along here, which you would think would be the 6th nerve, but it's really, the 6th nerve runs much more medial, but I think it still must be involving the 6th and its course, because there's no other nerve that should be involved here besides the 6th. Okay, another patient with 6th nerve palsy, another unusual condition. not bad. Somebody mentioned again Lyme, lymphoma. But this was an unusual case. Pontimyelonitis, Nate mentions, not a bad idea. Does the new image help? Correct. As Nate said, this was DVA. Notice the developmental venous anomaly that in this case caused a 6th nerve palsy, not in the region of the nucleus, but where you can see that that's where the nerve is traveling within the pons. And here was an unusual case. An 18-year-old came with a 6th and 7th nerve palsy, had negative DWI. There was no abnormal signal on the flare, but following contrast, there was a little bit of enhancement, kind of in a linear fashion, both on the sagittal and the coronal plane. And we thought that likely this patient had some sort of a small vascular malformation in the region of the 6th and 7th nerve nuclei, which was causing the patient's symptoms. What's the etiology here for a 6th nerve palsy? Correct. As Nate and Ben both said, cavernomas, which actually bled. So this likely a cavernous angioma with hemorrhage, as we can see because of the bright signal, combination of the dark and bright. Okay, what is this abnormality with a bilateral 6th nerve palsies? It was mentioned earlier in this talk by somebody. Correct. As Ben said, and Nate, this is osmotic demyelinating syndrome, which is not the appropriate term, but central myelinolysis. An interesting thing that these images became normal in a follow-up study 6 years later. Okay, this patient presents with a 6th nerve palsy. What is the abnormality? What structure is involved here? No, the basal artery is fine. What is the abnormal signal in the pons? What structure is involved? Remember my first talk? What sits right in the anterior part of the medulla in the pyramid? What structure sits in the pyramid, which is very small here? Correct. As Matthew said, the corticospinal tract. This patient had an infarct a while back of the corticospinal tract, as we can see, as there's atrophy of the pyramid on the left side. And again, if you look at this diagram, notice that the fibers of the 6th nerve run very close to the corticospinal tract in the pons, and likely because of this close proximity, this 6th nerve palsy was because of the stroke involving the corticospinal tract. And that brings up a similar situation. Anybody knows what a Rayman Syndrome is? a very unusual condition, but a similar situation. Rayman syndrome consists of a 6-nerve palsy and contralateral hemiplegia. Again, so here's a stroke involving the corticospinal tract. So this is on the right side. So this patient would have had a left hemiplegia and a right 6-nerve syndrome. Again, notice the close proximity of the 6th nerve to the corticospinal tract. So that's what Rayman syndrome consists of: 6-nerve palsy and contralateral hemiplegia. This is an unusual case of a immunoblastic lymphoma, kind of the horseshoe type involvement in the pons involving both the 6 and 7 nerve nuclei. This was a patient that we had that really struggled with the diagnosis. The patient had a brain biopsy. Patient again presented with a 6-nerve palsy and INO, and we can see this abnormal signal, which actually was quite extensive. She had multiple areas of abnormalities in the brainstem, the pons, and the basal ganglia. And the final diagnosis was progressive autoimmune cerebritis. But in presenting symptoms, again, were 6-nerve palsy and INO. Again, likely because of the involvement of the region of the nuclei. And if we look here, again, the MLF and the 6th nerve, and you can see this abnormal signal in the location of the facial colliculus, anterior to the facial colliculus. This was a patient with breast carcinoma and was unable to abduct both eyes. And again, a similar lesion here. We weren't sure if these was really metastatic disease or reaction to the chemo and radiation, because there was really no enhancement, but there was this very abnormal signal, again involving both 6 nerve nuclei. And of course, I cannot avoid showing this abnormal both 6 nerves. What's the condition I show with every nerve? Correct. As Gino and Nate mentioned, hemosiderosis. This patient was operated for GBM, and we can see the extensive siderosis also involving both 6 nerves. Okay, why do we have enhancement of both 6 nerves here? A common condition that also Asif mentioned siderosis on the prior case. Okay, Nate right away came up with a common condition we see, lymphoma or leukemia. This was non-Hodgkin's lymphoma. You can see involvement not only of the 6th nerve, there's also within the ISC, there's abnormal enhancement. This was a patient with ALL, again, involvement of both 6 nerves in front of the pons. This patient presented with intermittent multiple cranial nerve symptoms, and we can see the 5th enhanced, the 6th. For a long time, people thought that this patient had sarcoid, which turned out not to be the case after brain biopsy. This was a case of idiopathic hypertrophic pachymeningitis and not neurosarcoid that was considered for a long time in the differential. This is unusual. This was a 13-year-old who had a right Bell's palsy, and it was followed later by 6 nerve symptoms. And again, we see the multiple nerves involved here, the 5th, the ISC, but of course the main thing here is to show the 6th nerve, which was the second set of symptoms the patient developed. And again, this was a case of Lyme. The symptoms changed from Bell's palsy to sixth nerve palsy. Now I'm showing this another case of Lyme because you can barely see anything here on the axial plane, maybe a little bit of enhancement, but it's much better seen on the sagittal. You can see here, as I showed before, in the normal, this is a normal sixth nerve, and here we see on this patient the enhancement on the sagittal plane. Again, explain the patient's sixth nerve symptoms, but better seen on the sagittal than on the axial plane. Case from the literature, question diabetic neuropathy, which caused some enhancement of the right sixth nerve traveling towards the Dorello's canal. And we can see it pre and post contrast is also on the coronal plane. Okay, what's the abnormality in this case? Correct, as Nate said right away, trauma. Severe fracture here. A lot easier seeing here. This was severe accident. Notice the unusual fracture of the clivus. And this patient had bilateral sixth nerve palsy, also a left horner, and you can see it because of this trauma of the clivus that I'm sure both Dorello's canals were involved here, and you can barely see the sixth nerve here because of all the edema or the contusion in the region of the clival fracture. Okay, what is the abnormality here? Somebody mentioned meningioma, but it's not the case. There's no tumor here. There's nothing wrong here, but there's something missing. What is missing? Correct. Finally, Nate, Asif, Matt, all mentioned that there's no right sixth nerve. This was a young child. Notice the sixth nerve, this is actually the trigeminal, but no right. Anybody knows what this syndrome is called? Somebody's typing. No, this is what's called Duane syndrome. This kid will present with problems with ocular abduction, and many times there will be an absent or atrophic abducens nerve. And in this case, the right sixth nerve was absent. Actually, this was discussed at length in one of the, I think, Saturday or Sunday courses at the last ASNR meeting of this year. And actually, a case was shown with both sixth nerves absent. There was all the long discussion of the genetics of Duane syndrome and the various variations. And they showed this example of absent bilateral sixth nerves. Okay, what is the abnormality here? Correct. Gino right away jumped to the correct diagnosis. Notice here the encasement of the sixth nerve. And of course, the diagnosis is even more obvious on the DWI with this marked restriction and epidermoid here encasing both six nerves. Another condition involving Dan and Gino mentioned schwannoma. Another possibility. Remember, when you mention schwannoma, you should think of something else. Again, as Nate mentioned, meningioma. I don't think we can really differentiate, but this case was a meningioma. It was proven by biopsy, case from the literature. And here's a patient with diplopia, one of our cases, diagnoses. And Asif mentioned correctly meningioma, but again, it would hard to say, is it a schwannoma or meningioma? In this case, we see the marked enhancement. And again, notice the normal sixth nerve on the left side, and where we'd expect the right side, there's this big lesion. We cannot even identify the nerve. And this was a clival meningioma. This was a case that was followed for several years without any change. Patient had diplopia and a sixth nerve palsy. We don't have the definitive diagnosis, but we have an idea. Any diagnosis here? Cystic schwannoma, possibly. Something else? What lesion is usually bright on T2? Besides the cystic schwannoma? Venous malformation? Possibly. What lesion can occur in the clivus? Correct. As Gino mentioned, and Ben, we felt that this most likely was a chordoma. The patient, as I said, was followed for many years, and we felt that this is the most likely diagnosis. Again, notice in this coronal image, here's the lesion, and you can see, again, on the normal, so here's the cavernous sinus, the sixth nerve, and the Dorellos canal, and the third above. So again, Meckel's cave, Meckel's cave, the sixth nerve, and the third above. And you can see how, in this case, the sixth, the region of the Dorellos canal would be involved. Why this patient presented, and always had a sixth nerve, no other symptoms. This was a patient who had a lung adeno and progressive left sixth nerve palsy. And if we look at the diagram at this anatomic specimen, notice here's again Dorellos canal with the sixth nerve, and we can see this metastatic lesion involving the clivus exactly in this location, also seen on the sagittal plane. And again, here it is. Here's the Dorellos canal, this carotid artery again involving the clivus. causing the symptomatology. Why am I showing this case? That's true. Besides, the last case then said chordomas are usually in the midline, but have been described also being eccentric to the side. So that's it's unusual, but chordomas can be to the side of the clivus. Okay, back to this case. Normal, abnormal. Okay, at least the site of abnormality was mentioned over here. But what is it? No longer meningiomas, something else. Lymphoma, possibly. A MET is not a bad idea. Dan mentioned a MET. From what condition? Cannot really belabor it because it could be any MET. This was a prostate MET. Patient presented with a 6th nerve palsy. Again, beautifully showing the involvement of the regional Dorellos canal in the clivus. And there was also a little bit extension into the prepontine cistern. This was another prostatic MET presenting with a 6th nerve palsy. And again, here's the lesion. Here it is following, on the flare. And again, we kind of can see the 6th nerve here kind of encased within the lesion that is mainly involving the region of the Dorellos canal and also projecting a little bit in the prepontine cistern. Okay, what's wrong here? Correct. As Nate said, aggressive destruction. Notice the petrous apex is completely gone here. We can see it here on the CT, on the bone windows, and on the regular. And here it is on MR. And notice the abnormalities of the mastoid. Also notice that the carotid artery is being displaced here anteriorly by this very extensive. And this was a patient had a resection of the left parotid adeno-CA and came in with a left abducens nerve palsy because of the extension of the tumor into the clivus and petrous apex. And again, notice all this tumor here, the enhancement, and again, this is the normal nerve in Dorellos canal, and this is all destroyed here. This was a thyroid carcinoma. Patient presented with a right abducens nerve palsy. Again, notice the marked destruction of the clivus and the petrous apex. Explain again the symptomatology. This is an unusual case from the literature, progressive 6th nerve palsy, and the lesion was a ganglion neurofibroma involving the region of Dorellos canal, again, as seen on this anatomic specimen, both on the coronal. Again, here's the 6th nerve in Dorellos canal, and here's this destructive lesion. This was an unusual case. We don't have a diagnosis. This was a young woman presented with a 6th nerve palsy, and she only came for a study, and then we lost follow-up, so we have no answer as to what this lesion is. and we can see this enhancement. There's a little bit of hyperostosis and deformity of the posterior clinoid. This was a CT done. She only had 2 studies. And again, notice there's a little bit of hyperostosis, and it was not clear if this was a meningioma, schwannoma, maybe a osteochondroma or osteosarcoma, but we have no answer as to what this lesion was. But definitely abnormal with severe 6th nerve palsy. Okay, this patient presented with eye pain and 6th nerve and 3rd nerve symptoms. Any diagnoses? Somebody mentioned a CC fistula. It was not the case. Meningioma. No, I'm done with meningiomas. Anything else? What side is abnormality, by the way? Correct, as Nate said, the right. Any other etiology? Thrombus. Oh, no, I'll show another image. Maybe that'll help. Any diagnoses now? Nate has mentioned the right diagnosis. Nate and Gino. Aneurysm. Correct. You can see on the post-contrast this large structure here. More images are needed or will be welcomed. So here's the lesion. What about the CTA and MRA? What possible aneurysm is that? Originating from what vessel? PCOM, as Asif said, correct. Notice on the angio, a massive PCOM aneurysm. And the interesting thing here, is what has happened. This aneurysm has eroded the right side of the clivus. And that will explain the patient's symptomatology of the 3rd nerve and the 6th nerve. Again, if we look at this anatomic diagram here, so here's the 6th nerve entering the Rallis canal, the 5th nerve, and the 3rd nerve. And if we look at this coronal anatomic specimen, dorsum celli, the 3rd nerve, the 6th nerve, and the Rallis canal, and this is Meckel's cave. And all this area was eroded by the aneurysm. So again, if we look here, specimen, and here it is on the coronal T2. So this is the Rallis canal with the nerve within it, Meckel's cave, and the 3rd. And notice how this erosive lesion, the aneurysm has eroded this entire right side of the clivus. So this is all eroded here, and that explains why the patient had a 3rd nerve and a 6th nerve palsy. Okay, patient presented with a sudden left lateral rectus palsy. What is the abnormality in this patient? Correct. As Asif mentioned right away, a persistent trigeminal artery. There's a vessel here which should not really happen on this image, the axial of the CTA. This angio is not from the same patient. This was just the 3D that Kathy did and this is an angio of a different patient, but this is a kind of a classic appearance of a persistent trigeminal artery which communicates with the carotid and an embryologic remnant, and the most common of the three, the hypoglossal, aortic, and trigeminal. And here we can see in this patient the persistent trigeminal artery on the CTA reformatted images. And we can see nicely why this patient had 6th nerve palsy, because here's Dorello's canal where the nerve should go in, and the trigeminal arteries penetrating and joining the carotid, going right through Dorello's canal. And we can see it actually also. So here it is on the sagittal plane, here it is on the axial plane, and on the coronal, here's the clivus, and this is the trigeminal artery sitting in Dorello's canal. Why this patient suddenly developed the 6th nerve is not clear, but there must have been some hemodynamic change. So again, if we look at the diagram, here's the 6th nerve, and again, so the trigeminal was within Dorello's canal. And we can see again nicely on the MR, so here's the clivus, here's the region of Dorello's canal, and this is where the trigeminal artery was sitting, involving the 6th nerve. Actually, we can see it here entering into Dorello's canal. Anybody know what Rayman Syndrome is? Not seen very commonly anymore in the age of antibiotics. That's right, as Gino says, face pain, ear pain, and ophthalmic V1 abnormalities. So again, it's otitis media, petrous apicitis, diplopia, and also has abducens nerve palsy. I think we've only had one case, but anyway, this is a case from the literature showing this marked inflammatory changes, and you could see why you would have, again, 6th nerve palsy because of involvement of the Dorello's canal in the clivus. This is both a clivus and a petrous bone inflammatory disease. Okay, why am I showing this case? What side is the abnormality on? Everybody's picking the wrong side. Correct. Everybody switched to the right side now. The right side, as Asif, Ben, and Nate mentioned, there's marked abnormal tissue, maybe not the best image of the right side of the orbit. And the reason I'm showing that, this is what's called pseudo abducens palsy. This was pseudo tumor involving the lateral rectus muscle on the right side. So the palsy was not due to a nerve lesion, but actually to the muscle itself. So this is a pseudo abducens palsy. And what's wrong in this patient? Correct. As Gino and Ben said, there's atrophy of the left lateral rectus. So again, this is a pseudo abducens palsy. This was post-traumatic atrophy of the lateral rectus. So the muscle itself is involved, not the nerve. And how about here? Last case I'm showing. Abnormalities on which side? All right, there's Gino, Nate, Ben, Matt. Everybody picked the right. There's atrophy here of the right lateral rectus. And what's the cause of this? What's causing the atrophy of the right? Right, there's Asif mentioned. What kind of a lesion was here? But the location Asif mentioned, correct. And Gino mentioned the disease. This is MS. MS involving the sixth nerve nucleus. So what is the disease here? What did MS cause? It caused denervation atrophy. So this is denervation atrophy of the lateral rectus muscle secondary to MS involving the sixth nerve nucleus. And this is the last case I'm going to be showing today. And next week I will be proceeding to the cavernous sinus. Thank you for your attention and all your responses.